As you go deeper into pain management and palliative care, you will learn how to address psychological suffering, how to assess and how to manage. But let me just make a couple of points. One of the most important things is to build a relationship. This is not true only for palliative care, this is true for all medical and nursing service. If you want satisfaction out of your work, your patient has to trust you, has to like you, has to have enough faith in you to disclose the fears and anxieties to you. Now, building that relationship is very important. How do you build a relationship? One of the fundamental things to remember is to respect the patient. This is not the medical science that you ordinarily find in textbooks, but this is essential. I have a respect for each one of you because I know that you are superior to me in some way. Each one of you is superior to me in some way. Maybe you are stronger emotionally than I. Maybe you are physically more stronger than I. Maybe you have abilities, singing, dancing, I don't know what. Everybody has something that is superior to me. When I know that for a fact, that helps me to behave to you with respect. Unfortunately, in a way, I call it unfortunate, our profession gives us a lot of power. The power of medical knowledge, the power to influence human lives. The other person is weak. He is powerless. He has been deprived of even dignity. He is deprived of physical well-being and mental well-being and social interactions. He doesn't even have voice to scream in protest. This huge imbalance of power, the power that the doctor holds over a human life and the weakness of the individual, sometimes causes the doctor to abuse that power. We don't even realize that it is creeping upon us. Wherever there is power, there is a tendency to abuse it. It's not only for doctors. But here, it becomes particularly cruel because the person is so weakened and at our mercy. So, I'll repeat that. It is important to have genuine respect if you are to build a healthy relationship with the patient. Another requirement is to be non-judgmental. It may sound easy, it's not so easy. We all like good patients who are always smiling and thanking us. We don't like complaining people. If you know that the patient has been a drunkard, or if you know that the patient has been a drug addict, though modern science recognizes alcoholism and drug addiction to be diseases with genetic predisposition, most of us nurse a prejudice towards people like that. If you know somebody to be a wife beater or somebody who abuses the children, then you are prejudiced. If I am to have a good relationship with that person, whether he was a criminal or whether he is angry with me or anything, it's not easy, but I'll always try to be non-judgmental. I will remember that I have been given this privilege of being able to help this person. I have not been given the job of judging that person or playing God. I will treat him to the best of my ability, whether he is good or whether he is bad, by my prejudices or understanding. You can build a good relationship with the patients within seconds if you can convey that you care. If you acknowledge the suffering of the person feels understood. And by just that acknowledgement, you are conveying that you care. You don't have to say that I care for you. But suppose you started with your conversation with the statement, I see you are in pain. I see you are in a lot of pain. Are you in a lot of pain? One of these openings will be fine. Or it may be, I see that you are in distress. You seem to be suffering. You want to tell me about it? One of these statements, with the concern showing in your face, so long as it's genuine, will immediately reassure the person, my God, finally I have got to someone who cares for me. And then they are more likely to disclose their innermost feelings to you. And if they do, then you are able to help them adequately. Psychological support is not really something that is to stand alone. As you are assessing pain or other symptoms, the patient may give you cues. The patient may say, oh doctor, the pain is so bad. I do not want to live anymore really. Now, this unsettles us. We quickly are tempted to go on to, but tell me more about the pain. What kind of pain is it? Now, that cue should not be missed. If he says, I do not want to live anymore, you acknowledge the suffering. Say, oh, that means you are in such severe pain. And does that thought come to you frequently that you do not want to live anymore? And the response to the question will lead me to explore a little more and may make me ask, but this thought of suicide has been coming to you? I asked this question to a patient's wife, and she said, she actually smiled in a sad sort of way and actually said, well, not exactly suicide, doctor, but I thought of poisoning my husband and children and myself. I cannot bear to leave them behind. Now, remember, this is not infrequent. Most people who say this do not do it, but some do. And anyway, even if they do not, that indicates the degree of suffering. And once we understand why, we are able to do something more about it. Your treatment of pain or symptom itself may remove the desire for ending of life. The person who comes in today, doctor, please put me something into my vein and kill me. I cannot bear this anymore. Tomorrow may sit up in bed and smile and say, doctor, thank you very much. Do you think you can cure me? The agenda shifts. But there are some of these people who may actually be in clinical depression. You may try all sorts of analgesics or other medications and they just continue to grumble. And that could sometimes be because you are actually missing a clinical depression which needs to be recognized and treated appropriately. Do not assume that all the pain is caused by the depression. That is a mistake. We recognize that when somebody is in severe pain or other suffering, depression is a possibility. It's a contributory factor. One is not a standalone. They are problems that together cause suffering. We have to address everything. In the context of incurable illness, the patient's state of mind can be one of several. A famous psychiatrist who came to be called the death and dying lady who died a few years back, her name was Elizabeth Kubler-Ross. She identified 5 ways in which a human being may respond to a bad situation. Denial. This cannot be happening to me. This is not true. Anger. Why is this happening to me? How can God be so unjust? And you told me 1 month back that you think it's an ulcer. Now you tell me it's cancer. The anger maybe against fate, maybe against God. It's likely to be directed at you, and you need to recognize that this anger is a natural reaction which you yourself may be in if you were in his position. That will help you to cope and not react in anger. A third is bargaining. That is, you bargain with God. Oh God, I light 100 candles in such and such a place. I will go to such and such a temple and perform this puja. Please cure me. Or the bargaining may be with you. Okay, doctor, I will stop smoking. Please cure me. Or the bargaining may take the form of doctor hunting or system shopping, going from one doctor to another, or move from modern medicine to Ayurveda to homeopathy to something else to something else. And a fourth is depression. Just sadness, but with the possibility of a clinical depression. And the fifth, according to Kubler-Ross, is acceptance. Okay, it has happened. So now what do I do about it? Kubler-Ross herself has pointed out that doesn't happen in that sequence necessarily. And even if somebody has come down to the fifth stage, they may go back to the other. They may circulate between several of these states time to time. All that's possible. And these may not be all the reactions to a bad situation, but it gives us a good framework for us to remember and to try to understand the person. The trick is to listen enough to what is being said, but also to what he doesn't say, what you read from his face or from his body language. Try to understand the person, accept him in whatever state he is, and then try to help him.